Uh, a very good afternoon, everyone. Good afternoon. Please be a little bit responsive. Good afternoon, everyone. Okay. Today I'll be conducting clinical discussion on topic advanced clinical management of HIV-TB co-infection. I don't want this clinical discussion to be as same as we used to conduct. I want you all to respond more also because I might know much even if I'm presenting. So I want from your insights also. So HIV, we all know that. HIV and tuberculosis as co-infection. So before starting, I'll just say tuberculosis is like an opportunistic infection in HIV positive patients. So why DB is present is that when HIV is infected in the body, it depletes it depletes the CD4 cells. We all know what is CD4 cells and T lymphocytes, white blood cells present in our body. It depletes the cells in the body, and it gives when there's decrease in the immunity, it gives an opportunity for the tuberculosis to come and attack, and that is how HIV and tuberculosis coexist. So let's talk a little bit epidemiological study about it. Tuberculosis is the leading cause of death, obviously, among people living with HIV. So, and the next is HIV increases the risk of progression from latent TB to active tuberculosis by 20 to 30 fold. Do you guys all know what is latent TB and active TB?
Yeah, symptoms are not visible yet.
Yeah, latent. I'll just explain a little bit. In simple words, latent TB, even the TB tuberculosis is present in the body, but it's not active. Like it doesn't show any symptoms yet. And I'll go to the next line. High prevalence in sub-Saharan African and Southeast Asia. Multiple drug-resistant tuberculosis are more common in immunocompromised patients, and the co-infection significantly increases the hospitality and mortality in patients. Let's go to the pathophysiological interaction between the two diseases. It is called as a bidirectional synergy, which means the HIV can affect the tuberculosis more severely, or the tuberculosis can affect the HIV more. That is called bidirectional synergy. So, as I've said earlier, before HIV depletes the CD4 cells and T cells in the body, and which impairs the mediated immunity. CD4 cells are the protein receptor present on the surface of the T cells, and when HIV infects on the CD4 and T cells mainly and decreases the immunity, and that is how people get HIV positive. And for example, when the patient have HIV infections, it destroys the CD4 cells and T cells, as I've said, and as CD4 cells are mainly essential for the mediated immunity in the body. So when CD4 cells are severely destroyed, or like it becomes very low, then it cannot able to control the TB infections in the body, and CD4 releases cytokines, and cytokines releases macrophages in the body, and macrophages are responsible to kill the TB cells in our body. And the next is when the patient have tuberculosis, since macrophages kill the tuberculosis in the tuberculosis infection, the cell becomes activated macrophages. The cell becomes the immune is activated, and HIV is type of a viral infection that it seeks the opportunity that the cell is activated so that it can able to replicate more, and that is how high cytokine release accelerate HIV progression. And advanced immunocompression increases extrapulmonary and smear negative tuberculosis. This one is like we do sputum test in tuberculosis, right? So why sputum is that when the tuberculosis infects in the lung cavity, it forms small cavity in our body, and where the bacterial tuberculosis mycobacterium, obviously it stays in that in the small, in the vessels, or and then that is how we able to detect it through sputum test. But the thing is that when the CD4 cells is lesser than 50 cells per mm cube, normally it's 500 to 1500, but in patient severely infected lesser than 50, the cavity in the lungs, it becomes less, and then we can't the bacteria doesn't stays in that cavity anymore. That is how we get false negative reports even though the patient have tuberculosis. So that is the thing. And this is a guideline-based timing of ART. What is ART, guys? Oh, of course. Okay. Can anyone tell what are the ART? Okay. Everyone is very clear with this, so we're just gonna have a warm-up session. Okay. Here now I have mentioned about CD4 cells. Lesser than 50 cells mm per cube. Initiate ART within 2 weeks of starting tuberculosis therapy. That means HIV and tuberculosis are present both together. So which one should we start first? Tuberculosis, right? So it says like if it's lesser than 50 cells, so we'll initiate our therapy within 2 weeks of starting tuberculosis therapy. And if CD4 is greater than equal to 50 cells, initiate our therapy within 8 weeks. Why? Because in CD4 cells, if it's lesser than 50, that means the patient has severely infected with the virus. So we have to initiate more rapidly. We have to initiate the treatment in a faster rate. And here, if it's little bit, if it's greater than 50, then means it's still not that severely affected. So we can initiate within the 8 weeks. Within the 8 weeks, and then tuberculosis meningitis is when the tuberculosis cross the brain, and we can consider delaying ART due to high IRIS risk. This IRIS risk is the full form is immune reconstitution inflammatory syndrome. So what is this? Is that when HIV and tuberculosis, we treat to increase the immunity in our body, right? So when we give our rapid and like fully give immunity support, there might be chances that the treatment might give a negative feedback again. Like suppose lymph nodes. There's like when we give certain immunity boosting, then it might give there's like we're changing the biological cycle, right? Like when you push, when you're just walking, someone is walking and you push forwards, right? Like so that is how it works. And you will find like lymph nodes present, and then multiplication of you find everywhere. That is like the simplest example I can bring. And early ART reduces mortality but increases IRIS risk. This is a standard regimen treatment. Tuberculosis, we know it's normally its intensive phase is 2 months of HRZE. What is H? R? Okay, followed by continuation phase there. So there is intensive phase of 2 months of HRZ and continue 4 months of continuation phase with HR, that is isoniazid and rifampicin. And for HIV, ART therapy is tenofovir, lamivudine, and dolutegravir. Okay, as we all know, rifampicin is like a very intensive CYP450 enzymes inhibitor, right? So I want you all to check open your lexicon and check the drug-drug interaction between rifampicin and dolutegravir. So if you check, you'll find that rifampicin will decrease the effect of the DLT, say. So when the treatment is going with rifampicin, then you have to keep double the dose of dolutegravir. That is, I'll talk later in the next slide. And efavirenz-based regimens acceptable with rifampicin, and protease inhibitors require dose adjustment or rifabutin substitution. With regards to protease inhibitors, we all know that protease inhibitors are also a class of drugs of ART, right? There are like, I think 1, 2, 3, 4, N and RI. There are like 4 types class of drugs. So in protease inhibitors, it requires dose adjustment, or you can just change to rifabutin substitution. Rifabutin is also like an antibiotic, and avoid overlapping hepatotoxic drugs without monitoring. As we all know, the tuberculosis drugs are all hepatotoxic. And some simple drug-drug interactions. Rifampicin is a potent CYP3A4 and UGT1A1 inducer, and reduces plasma concentration of dolutegravir, protease inhibitors, and NNRTIs. As I said earlier, dolutegravir requires 50 mg twice daily with rifampicin because it decreases rifampicin decreases the effect of dolutegravir. Rifabutin preferred when using boosted protease inhibitors regimens, and the induction effect persists 2 weeks after rifampicin. If the toxicity is there after initiating rifampicin, there is still because of long half-life, it persists still 2 weeks, so we have to wait until the next regimen is continued. Those optimization strategies and pharmacokinetic and pharmacodynamic approach for us, like it's like increase dolutegravir dosing frequency during rifampicin co-administration, and then adjust tenofovir dose in renal impairment, that is when the creatinine clearance is less than 50 ml per minute. And then of course, weight-based dosing is essential for tuberculosis drugs and TDM in high-risk patients. Derivative drug monitoring in patients, actually our hospital, we don't do it, but recently I attended a CME program in Kerala where it was about TDM in beyond vancomycin. So the hospital, they conduct TDM in patients, and they have showed a very positive impact on that. And if we can implement TDM in hospitals, then it will be a good thing. But since TDM can have like it's a bit costly, and then samples, there is like, if you don't get the samples correctly at the right time, there will be the result might not be that much efficient. Assess adherence and malabsorption in treatment failure. Pharmacogenomics and precision medicines. Here, see polymorphism affects efavirenz metabolism, risks of CNS toxicity. This is something related to the DNA of the patients. Recent study have done some studies, so you can check it out in Google and all. NAD polymorphism influences isoniazide hepatotoxicity, and these are the genotypic resistant testing before ART switch. These are the genomic studies that they have done. I don't think we are doing here, but these are the advanced versions of how you can detect everything before you start anything. And comprehensive monitoring, of course, the monitoring parameters. Every drug have monitoring parameters. So obviously here will be LFTs, RFTs, viral load, and CD4 count. Because CD4 count, why it is so? Because we mainly focus on the CD4 level and give the drug. According to that only we can differentiate. And monthly clinical review during intensive phase, and monitor hepatotoxicity, HRZE plus ART overlap. And a viral load at 6 months to assess separation, assess for IRS within first 3 months of ART. Let's study a case. Case study 1, where it shows like low CD4 with rifampicin interaction. Patient is 32-year-old male. CD4 is 38 cells per mm cube. I say like less than 50 is like severely affected. So we'll initiate with HRZE for pulmonary TB, and ART plan will be the tenofovir, lamivudine, and then the dolutegravir. Okay, intervention is increase the same like I mentioned, like the DG to 50 mg BID, and outcome with viral separation at 6 months. And case 2 is hepatotoxicity management. That first one is according to CD4 cells, and this is hepatotoxicity management. 45-year-old female on HRZE and TLT, elevated ALT after 4 weeks, and the pharmacist suspected iron-induced hepatotoxicity. We play a very important role in this kind of studies because since the drug is a hepatotoxic drug, sometimes they, of course, the consultant doctors also know that it's hepatotoxic, but usually they want to treat the patient and they'll just give the treatment. But us, we can help them by doing all the studies, helping them in treating and temporary discontinuation and stepwise reintroduction and close LFT monitoring. Here, next study is case study is renal impairment. eGFR 35 ml per minute in HIV-TB patients on tenofovir-based ART. Intervention is dose adjustment or switch to alternative NRT, frequent renal monitoring and multidisciplinary consultations. This is interventions that we can do as a clinical pharmacist, and comprehensive medication therapy management and therapeutic drug monitoring interpretation, which can't be really possible, but we can in the near future. Adverse drug reaction reporting and prevention, that is we usually do, and guideline-based ART optimization and research and protocol development in HIV clinics. Guidelines-based ART, every now and then there's like recent studies or guidelines regarding everything is coming out, so we can be up to date, and then according to that we can help each other. And these are the references I took from WHO guidelines, WHO global tuberculosis report, and NIH guidelines for use of antiretroviral agents in adults and adolescents with HIV 2024. Recently, ICMR have done a study on shorter all-oral regimens for drug resistance and cost-effective in India. It's recently submitted, posted on 12 February 2026. Here they have checked the economic value in all the people who have tuberculosis. India as a whole, we are trying to eradicate tuberculosis for a little while, and ICMR have played a very important role. We can see in government hospitals, and also they have given like free tuberculosis treatment and screening because they are trying their very best to eradicate at least tuberculosis from India. These are some ICMR approved kits and system, ICR approved handled X-ray system for CXR imaging, and multiple drug resistant tuberculosis detection kits prospectively validated and approved by ICMR, and then ICMR approved kits for latent tuberculosis diagnosis. ICMR they have made a standard protocol on the diagnosis, the detection, diagnosis, everything, and standard protocols for evaluation of IVDs for tuberculosis, analytical performance evaluation (MTB) and MTRDB, clinical performance evaluation for MTB, and same as MTRDB, and concordance or equivalent study protocol. And these are the portals that we can report to. And standard generic MOA for validation for tuberculosis diagnosis by ICMR. Thank you. Is there anything you want to add into the